All right, good morning, everyone. We are going to get started. Happy Wednesday, and thanks so much for joining us. My name is Dana Slowinski, and I am co-owner of Family Recovery Centers. I'm just going to take a minute to talk a little bit about Family Recovery Centers for those of you that aren't as familiar with us. We are an evening adolescent intensive outpatient program, and we are DBT based. We also incorporate other modalities and experiential activities such as yoga and art therapy into our treatment. Two program highlights that I'd like to discuss are our family involvement. So parents are actually on site and doing their own work along with their kids 50% of the time. So they are learning the DBT skills with their child, and then they're also kind of digging in and doing their own work as far as their role within and dynamic within the family system. So we really get to look at the whole system when we're working with a family. And then we also have a 24/7 on call. So our staff is available to both the child and the parent 24/7 for skills coaching to help them not only when they're in program with us, but also in their own lives in difficult situations. Um, we work with a wide range of disorders and maladaptive behaviors. So we work with self-injury, substance use, some disordered eating, mood and anxiety disorders, bipolar disorder, kind of a wide gamut. We have 3 locations: Lake Bluff, Hoffman Estates, and St. Charles. And that is us in a very quick nutshell. We are very grateful for our community partnerships and our collaborations. And Owens and Associates Counseling is definitely one of those collaborators. So with that, I'm going to turn it over to Shannon with Owens and Associates.
Good morning, everybody. Thank you so much for coming to Recognizing Co-occurring. Clearly, I need more coffee. Recognizing Co-occurring Disorders in Adolescents with Mike Peila. Thank you to Rianne and to Dana and FRC for this amazing opportunity. We're so excited. Before I start singing all of Mike's praises, because I can, I want to let you know a few things about Owens Counseling. First, as you will see, we were smart to hire Mike. I am really having a hard time without coffee. Owens Counseling has been in your neighborhoods for 2 decades, and we currently serve 6 Illinois counties. We are nearby many of the FRC locations. We are in Libertyville, Lake in the Hills, Schaumburg, St. Charles, Warrenville, and Collinsville. And I'm sure you're noticing me counting in my own head that we have them because we just opened Libertyville in the beginning of the year and Collinsville earlier this month. So I'm getting the hang of where we're at. And Collinsville is way south, near SIU. One of our clinicians is moving that way. So we were lucky enough to be able to do that. And we're really proud of the ability to be able to continue to move into all of Illinois, and I'm pretty sure my boss would say and beyond. I think he's still looking at New Orleans. All of our clinicians see clients in person and virtually. It's completely about the comfort of the client and what they prefer. We offer 6 groups, both in person and virtually. 3 are for DBT, which we've been talking about already, dialectical behavior therapy skill building for our 11 to 14s, our 14 to 18, and then our 14 and above. We have 2 survivor groups, one for those who have endured sexual trauma and domestic violence, or one or the other, and then another for physical, sexual, and emotional abuse. Last, and certainly not least, is Mike's group, Being Mindful with Addictions. So without further ado, let me introduce Mike Peila. Mike has been with Owens for over a year and brings a passion, knowledge, and insight for clients with co-occurring disorders. Mike impressed me in his interview and has continued to do so with his straightforward, compassionate, and non-judgmental presentation that has never wavered. Mike is passionate about what he is about to share with you today, and I hope that you'll ask him all the questions that you have. He is a formidable weapon to have in your arsenal when trying to understand substance abuse and mental health. Without further ado, all you, Mike.
Wow. Thank you, Shannon.
Pleasure.
I'm very humbled by that. I'm here to since Shannon said it all about Owens, and quite honestly, I can't really add anything about myself aside from I'm here to talk about co-occurring disorders because it is a passion of mine, and it is a passion of mine because it's part of my personal story. When I was an adolescent, I struggled with these issues. Um, and unfortunately, like a lot of folks, there wasn't a whole lot of discussion about it from my part. So it comes to the development of negative coping skills, lack of understanding of what's going on, just dealing with the symptoms the way I knew how to best deal with them. And over the years, I realized that this is a very, very common theme, especially among folks with substance abuse. Um, so I put this PowerPoint together, recognizing co-occurring disorders in adolescence, because I think it's important to recognize some of these things as adults, as clinicians, as folks in the school system, to understand that substance abuse comes with other aspects of it that we may not be looking at for various reasons. Um, and without the knowledge, or at least a lot without the awareness that there may be other things going on, these coping skills continue and grow roots. Unfortunately, some of these paths that we set down are hard to veer off of, and they maintain for a long time. So I will get started. What are co-occurring disorders? Co-occurring disorders are basically is a term referred to folks dealing with substance use disorder plus another mental health disorder. Now, there's been other terms used to describe that. Dual diagnosis is one of them. It's referred to the same situation, but it seems to be going out of date. I'm not sure exactly why that is. Most folks in the business will know what you're talking about when you say dual diagnosis. But co-occurring is becoming more and more used. Comorbidity is also a term you may have used for this situation. However, it is a broader term that includes the existence of other physical and mental diseases. So comorbidity is more widely used for a wider variety of situations, as to where co-occurring is specifically substance abuse along with some other mental health disorder. Uh, so which comes first? That is like the chicken and the egg question at times. It's really hard to tell. I used to have a professor that every question I asked him, he began with, "Well, Mike, that depends." And that is a very good way to start this answer, because it really depends on the person, and one can lead to the other very easily, especially when it comes to mental health issues leading to substance abuse, which is basically primarily that person's desire to alleviate their symptoms. And they have found through social stuff that a substance may alleviate their symptoms to where they have, I guess, for lack of better words, I found the miracle cure, because this takes away my depression. This takes away my anxiety. This takes away my thoughts from trauma, and it they have found something that helps, and they didn't need to talk about it. Um, they just started using, and unfortunately, this, as I mentioned, can grow roots and unfortunately set down some pretty heavy paths. Substance abuse also may trigger, and this is the opposite way. So much like trauma, if you guys have ever read the book Body Keeps the Score by Vanderkolk, she discusses or physiological changes that take place when folks go through trauma. Substance use can act the same way. So substance use can trigger mental health disorders that in someone who has predispositions to these areas of difficulty. Um, so yeah, moving on. Some statistics. Now this is a difficult topic in this arena. Um, and it is because you'll find numbers. But when I always look at numbers when in statistics with this situation, I'm always kind of like, yeah, well, this is the numbers they have. This is the data they have. But you got to look at the other issues that are going on. Stigma is one of them. So to get good statistics, you need data, right? You need data from where you gather this data. You get it from folks going into substance abuse programs, folks seeking help for mental health, um, or you get it from surveys. Now, you're asking people, and especially in this case, adolescents, to be honest and forthright with their mental health issues and their disorder and their substance use. So the stigma that goes along with some of those may prevent some kids from discussing it, uh, and that's a barrier. We'll discuss barriers later, but stigma affects these numbers. Rules and laws, just like stigma, kids don't want to come out with the fact that they're using a substance that they could get in trouble for, right? Rules in the family, laws in our society, they're a lot less likely to say, oh yeah, I do this, I do that, when they have been told for years that this is something you don't do, and if you do, you'll get in trouble for it. So they are very, I don't want to say unlikely, but less likely to discuss these things because of those. And then there'll be cultural issues that stop people from talking. These are all these things I discuss later in barriers. So we will come back to that. Estimated rates of co-occurring mental illness and on adolescents with substance abuse disorders can be up to 75%. I actually think that this number is kind of low. And I think it's low because of the reasons I just mentioned. Um, Folks with substance abuse don't come out with what they're feeling psychologically, or they think that what they're dealing with mental health wise is it may be dealing specifically with the drama that they deal with in society and all of this stuff. So they kind of put mental health or their mental illness or disorder, they don't really discuss it. Um, so I think the numbers is low, but this is actually kind of a high number. However, this is with substance abuse disorders and having mental health, right? So substance abuse first. So most of these numbers come from folks going into a treatment center and then realizing that they have other stuff going on. And then when you go the other way, it's even more difficult because of the stigma and the law and the culturals. But youth who experience serious depression, which is a major depressive episode, they're twice as likely to use illicit drugs or alcohol than peers who have not. So out of all the studies that I've looked at and such, major depressive episode has been a statistically determining factor of a rise in substance use. Um, of course, some of the other aspects of it are hard to say because of the barriers that I discussed. So some of the risk factors, of course, genetics, right? Genetics has a way of leaving us predispositioned to specific mental disorders. You know, it's why anytime you see an intake for to come into therapy or to a facility, they'll ask you about your family history with psychological aspects of your family, because some things can run in your family genetically. That also goes with substance use. They've done studies that say alcoholism and drug addiction you can be genetically predispositioned to have these issues come into your life. And then other issues are environmental. neglect and or abuse at home. Of course, now you're looking into the trauma part of it. Our environment has a massive effect on us, has a massive effect on how we think, how we feel, how we behave, and neglect or abuse can push these things. Poverty, living in an impoverished area, everything, I don't want to say everything is more difficult because life is rough all over, right? However, if you're living in poverty, there's a lot of social things going on that are much more, could be more traumatizing and whatnot. And I'll get to that a little bit later too. Isolation. When we isolate, we leave ourselves open. I had somebody tell me this a long time ago that I like to share with others when I discuss this is when our mind is like a bad neighborhood, we don't want to go there alone. The more that we spend isolated, the more those gears start turning. And the more we start justifying thoughts, the more we start justifying emotions and behaviors through distorted cognitions. And these things grow roots too, to where we come out of these isolation with facts in our mind that aren't truly facts of how we feel about something, how we behave in certain aspects of life. Isolation is never good. Exposure to violence and trauma. Now, this is outside of the home, and this is where the impoverished part of it, society I was discussing earlier, how you may be exposed to violence and traumatic experiences that that may trigger things. You know, you may feel unsafe. You may develop anxiety from the violence and trauma in your area. You may, to relieve symptoms of that anxiety, you may turn to a substance use to calm those symptoms, etc. Mental health disorders contribute to substance use and substance abuse. And that's kind of what I was talking about earlier. When mental health disorders come first, a lot of folks will reach to the substances for that relief. And then it goes just opposite. Substance use contribute to mental health disorders. So these are risk factors because if you look at it at an adolescent that struggles with mental health disorders, one of the things you need to watch for is how they're coping with their disorder. Are they building positive coping skills, or are they running to substances that are easily available in communities to calm these symptoms? And if you see a kiddo with substance abuse, you know, he's caught in school with smoking weed or whatever. Don't just look at it like, oh, he's defiant. He's got a drug problem. Look for what drives that substance use, that this may be an actual mental disorder that he's looking at, and not just the substance use. So most common substances used, which I think most folks would agree here, alcohol, because it's the most common used in our country, to be honest. And when I think most people know the effects of alcohol and what to see or how to see that in others. Decreased inhibitions, increased comfort socially, decreased feelings of anxiety, worry. All of these things are, calming effects if you're thinking in terms of especially anxiety. Higher levels of alcohol, that's when somebody's kind of pretty drunk. It's even more obvious, right? Risky decisions, decreased coordination. 21%, it is said, again, I believe these numbers are actually higher as well. By 8th grade, and 58% of 12th graders have tried alcohol. Marijuana, which is becoming even more increasingly used as of lately. Not that it wasn't widespread before, but since there's become a legalized aspect of it, a lot of people are using that as more of a reason to use. And that spreads down into the kids. The kids see that as well. I've heard from several of them, but Mike, it's legal now. It's like, well, that doesn't mean it's any less dangerous, or it doesn't mean that it's any less important that you recognize that you're using this to combat symptoms of a mental health issue. But the feelings of that, and as you can see, um, can be very calming, euphoric high, reduced stress and worry, increased feelings of well-being, slowed reaction, impaired coordination. These are things that if you are up in anxiety and having panic and stuff like that, these are very welcoming traits. You know, it's like, gosh, give me that. That's my cure. You know, unfortunately, that's where a lot of people look at it, especially when adolescents find it and they're like, oh, wow, this is beautiful. I'll stick with this. Now, when I put withdrawal on here, they say that we're not supposed to be actually physical withdrawals from marijuana. I have found that to not be true, and I think there's more studies coming out that that's the case, that there are withdrawal. I put that on here and wanted to discuss it because if a person smokes a lot of weed and uses it as a coping skill a lot, anytime they may have increased anxiety, or they may be in school and something is making them feel anxious for some reason, they know that that weed is there. They know that that weed will help, but they can't access it at the time. So their need to calm these symptoms may come about in feelings of irritability, anxiety, even changing in sleeping patterns. 6% of eighth graders and 45% by the time they graduate high school have used marijuana in these statistics. Prescription stimulants, Adderall, Ritalin, etc. I put prescription stimulants here and left out caffeine, but I probably should have included that in this slide, mostly because of the popularity of energy drinks with the caffeine and the taurine and all the sugar and all that. There's a lot of kids that suck that down like it's water. But these stimulants increased energy, decreased need for sleep, diminished appetite, euphoric high, this performance boost. You know, some folks start using these stimulants to boost their performance in sports and academics, and find themselves using it to the point to where they're developing a disorder by using it. Prescription opioids. These are, of course, more and more common. Several years ago, our country started having this big uproar in doctors prescribing opioids for small injuries and stuff like that. And they're a well-known drug that is bought and sold on the streets now, and that especially in high school and even middle schools. It's become kind of more of a normal thing. But I mean, if you look at the what you get from it, you can see why. It gives a peaceful, calming effect, reduces stress, anxiety. It will decrease worry. So you could see why someone that is struggling may reach out to this, because it feels numbing. It feels, I can breathe. Um, Prescription tranquilizer, benzos, which are Xanax and Valiums, but Ativan, Klonopin, Ambien. And these are the same types of stuff: reduced tension, reduced worry, anxiety, that causes drowsiness, some confusion, poor coordination. But all that stuff feels good when you're struggling with something like anxiety, or even depression. So some of the common disorders that are co-occurring among adolescents. Anxiety disorders seems to be at the top of the list. I have generalized, I put PTSD on here because it was in the actually where I got this information from. I also put PTSD in a section on trauma that I'll address later. But this includes social anxiety, obsessive compulsive, phobias, and it affects 32% of 13 to 18-year-olds. Again, I think that number is a little small. I think it's in reality, I think it's higher. And that comes with feelings of excessive uneasiness, worry, and fear. Depressive disorders. 13% of these folks of that age struggle with this. Depressed mood that affects thoughts, feelings, daily activities, sleep, eating, and play. It affects pretty much most areas of your life. ADHD, I think it's pretty common that folks know that attention and deficit hyperactivity disorder, that it relates to continued inattention or hyperactivity that interferes with their functioning, also with their development. 9% of folks those ages struggle with ADHD. Conduct disorders, which be oppositional defiant, intermittent explosive. Um, of course, it includes aggression, theft, vandalism, stuff like this. And I think when we look at conduct disorders, and I'll discuss this a little bit later too, we have to look at, I always look at kids that come to me and somebody else has diagnosed them with a conduct disorder. I always look at what is driving the conduct, not the actual disorder that they were diagnosed with itself. Although I keep that in mind, I always wonder what is driving this type of conduct. Trauma, exclamation point. So various various aspects of trauma, PTSD, acute stress, reactive attachment, could come in forms of anxiety or depression, maybe startle response. Trauma affects us in a very, I don't want to say bizarre, but it affects everybody differently. And one person's trauma is another person's party, which is odd, but that's very true. It's really from the eyes of that person. It's the experience of the event, not the event that itself that's traumatic. So we have to see how that event affects that specific person, because that may affect somebody else completely differently. It may not be traumatic at all. And if we don't look for or acknowledge trauma in the lives of children and adolescents, we end up chasing behaviors and limiting the possibilities for change. And that comes into play because we may be looking at their anxiety as an anxiety disorder, or their depression as a major depressive episode or a depressive disorder, when really trauma may be the driving force to it. So we're basically looking at treating something that we're not really treating the correct thing. So I think this statement here is very important. So I'm going to read it and focus on it. Adolescents who experience trauma through repeated abuse and neglect look to find a way to trust people who are untrustworthy, safety in a situation that's unsafe, control in a situation that's terrifyingly unpredictable, and power in a situation of helplessness. So they're looking to find trust, safety, control, and power, and all four of those are very much unreachable if you are an adolescent in an abusive or a neglected household. And where do you run? How do you alleviate this? Because that's your home. So effects that trauma can have on kiddos are their self-regulation of all three of these. Their ability to self-regulate their emotions, self-regulate their attention, self-regulate their behaviors are all affected by traumatic events. Their perception of safety is kind of out the window. They could either go one way and be afraid of small things and have the startle response aspect, or they could have the fact that the world view that nothing is as dangerous as stuff I've already lived. So they get more risque and more, not a whole lot scares them because they've seen a lot. So it really depends on the person. It can affect their self-image. Now this could come into play when it comes to like a sexual abuse and how a person looks at themselves after abuse or neglect and a traumatic experience like that. Or it could also come from psychological abuse. So if you're no good, you're not worth anything, you're trouble in my life, yada, yada. Unfortunately, there's a lot of kids out there that have parents that will run their self-esteem into the ground and they come out with low self-worth. Social relationships, how they react to each other is affected by traumatic experiences. Reduced alternate perceptions. So I have this on here because a lot of times when folks deal with trauma, they begin to start, especially adolescents, they can begin to start seeing things in black and white, right? It's a distorted cognition, black and white thinking. And anything outside of that, all these gray areas, they tend to push away as not valid. It's either this or this. So therefore, looking at somebody else's perspective of something is like it's usually not valid. And when you don't have that, or when you're lacking that, you lack empathy for that person. So yeah, the effects can be wide and broad. And when it comes to trauma, a lot of times it can mirror anxiety and or depression. And that's what I was discussing earlier, how we may look at somebody and they may discuss how they're feeling, and we may see that they're struggling with anxiety or depression, yet there may be something different driving that. So it may be a traumatic experience that is pushed these levels of anxiety to a point to where it's a disorder, and we're treating anxiety rather than trauma. It'd be nice to be able to treat both anxiety symptoms, but getting to the roots of the trauma will kind of help repair that foundation. Um, So moving on, common substances paired with disorders. So before I move on, I didn't address a couple of things that I think probably should be addressed, but they weren't in any lists that I could see of common disorders linked with co-occurring disorders when it comes to adolescence. Number one, people probably may be asking, and I can't see if you guys have any questions yet. So, but I'm guessing maybe somebody asked, where is bipolar? So bipolar is kind of a touchy subject when you talk about adolescents, because number one, they're in stages of development, right? So moods can be up and down. And I would not diagnose someone under the age of 18 with bipolar. And I know most other people wouldn't, but some folks will. The unfortunate part is a lot of kids self-diagnose themselves with bipolar disorder because of their moods. And that, I think, in itself can be a bit dangerous. But bipolar is not in there for those reasons, because these kids are still going through developmental stages that can mimic bipolar type of stuff. That's why even in the DSM, it discusses after the age of 18. And I also didn't include eating disorders, even though I put it on this slide later. Eating disorders, fortunately, aren't as prevalent as they used to be, like say in the 80s and the 90s. Although they're still there, and I believe still common, they weren't in any of the lists that I could find as far as co-occurring disorders when it comes to adolescence. It surprised me a little bit, so I included in this slide later, and you'll see why. Anxiety disorders. Some of the so if you think of these disorders as somebody reaching for something to calm their symptoms, and if you are feeling the symptoms of anxiety, alcohol, marijuana, opioids, tranquilizers, they all give these calming effects. So it's kind of they fit with this as far as self-medicating very well. Depressive disorders works a little bit differently because it includes all of the previous, um, but it includes stimulants. So the thing about depressive disorders is that a lot of times folks will pretty much reach for anything that changes the thought process. It doesn't matter what change it is, just change it because this sucks. So they'll run to various different ones: alcohol, tranquilizers, stimulants, but most can be used as an escape. Escape. Conduct disorders. Now, this varies depending on the individual's drive for the conduct. Like I was mentioning earlier, you know, what is driving this conduct? Is this person acting out in a certain way because he's just full of anxiety? Is acting out in this manner because he's overcompensating for lacking self-esteem, or I have I don't feel good about myself, so I'm going to act out and hopefully I can get friends that way. It's very bizarre when it comes to conduct disorders. That's why I always look for what's driving that conduct. And whatever's driving that conduct can be self-medicated with all kinds of different substances. Eating disorders, and this is what I was talking about a little bit ago. Um, Folks will run to these stimulants as an appetite suppressant. So that could be anything from the stimulants of the prescription aspect, or it could also come down to the no-dose that you find in the local drugstore. I don't even know if they make that anymore. I'm maybe showing my age there, but the White Crosses, the 357 Magnums, the caffeine pills, the bronchial dilators, that appetite, that suppress the appetite, but they'll increase, they'll be stimulants. And actually, if a person takes these on an often basis, it can produce the same type of behaviors that will be seen in a person that deals with anxiety. They'll be on edge, they'll be shaky, uh, they'll look like they're anxious mass. But they'll use those and abuse them because they won't be hungry. They'll feel the need not to eat. Interpersonal relationships and parenting. So now these are just things to look out for when it comes to watching a kid and how they deal with their relationships in society, as well as at home. Disconnecting from family and family matters. Now, this becomes a little sticky because you look and you think about it as to, or the developmental aspect of it is that, a lot of teenagers say, I don't want to deal with the family. I'd rather go with my friends. And this is a departure from when they were young and they did everything with the family. So you got to kind of be aware of developmental aspects about things too when you think about these things. That's why this whole subject can be a little tricky. And making assumptions can be maybe detrimental to actually helping the situation. But the disconnect from the family and family matters, disconnect from the peers. This is a little bit more of an important thing to see because kids connect through each other. They grow from watching and learning from each other far more than they do from us as adults. So when they start to isolate from their peers, it could be a sign that, hey, this is maybe something to look out for, whether it is the mental health, the substance use, or both combined. Changes in peer groups. Now they may be hanging out with the soccer team one week, and then next week they're hanging out with I don't even know the names of little tribes of groups and kids anymore. Maybe the headbangers or the punks or whatever they are referred to. Changes in peer groups may signify that, hey, this person's doing something different with his extracurricular time. And is this going in the right way? Is this a sign that this person is struggling with something, whether it be mental health or substance use? Clothing and attire. And this is kind of something that's a little tricky as well. Because what could lead people to believe that this person is making all these changes in their life and they're looking for different peer groups and blah, 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 could be just fashion statements, right? I remember back in the days, they would say, well, he dresses like a gangbanger. It's like, well, that's fashionable. So that really doesn't mean anything. It just means that he wants to be fashionable. And kids wear their quote unquote costumes to relate to people of their age, to their peers. And there's the promotional part. If they want to attract a different group of people, they'll wear specific clothing that group of people are wearing to attract that. So they might use it to promote themselves as well. I need to go quicker. Lack of interest regarding past enjoyed activities. And they may be into sports one week and then all of a sudden dump it and change their social groups and stuff like that. These are just signs to watch for. Decline in grades. I think everybody knows that if somebody is a honor roll student, and then the next semester they're failing, that something extra is going on. Anger, rebellion. Now, this can come in developmental stages as well, but anger can come out when somebody is dealing with a mental health disorder and they haven't found a coping skill that works yet, or they have found it and it's not available to them at the time, like substances. Barriers to recognizing. Are these mood changes typical with development? And that's where you got to be careful, because you have to know that the actual what's going on in that age and what is common for development of that age, and not make any assumptions, which I address later. Stigma in both directions. So recognizing co-occurring disorders in somebody, again, takes that person to be honest with you about their feelings and their substance use. But it also requires you not to see them, oh, they're just using substances because that's their way of acting out. No, you have to take that into account. You have to pay attention to your bias and how you see things, because they may not be how that person sees it. Guilt or shame. So a lot of kids are told, that drugs are bad. Okay, don't do drugs. So if they do drugs, there may be feeling this guilt that comes along with it. So that may be a reason they don't reach out and talk to somebody. Or shame of, oh, if I'm feeling something and something's wrong, something's tweaked with me and my mental health, then there may be a shame, like I'm not good enough. There's a lot of things when it comes to guilt and shame that keeps kids from discussing their issues, and they can be strong barriers. They're told not to discuss home, and this could be cultural thing. This could be just, we don't tell the neighbors stuff. It really depends. But when it comes to home use of drug and alcohol use and violence, you don't discuss what me and your mom do or me and your dad do or stuff like that. Trouble with parents. They think that if they do discuss these things, that they're going to get in trouble for what's going on with them. So they keep quiet. These are all barriers that are important. Illegal, trouble with police. If a kid says, even though weed is legal now, it's not legal for them. So they still feel that they're going to get in trouble with police if they come out and tell you that they're using marijuana, especially if they're using marijuana to cope with some other mental health disorder that they're shameful of having. Opening the door to communication. Be culturally competent. And I mention this because cultural competency refers to effectively being able to communicate with folks effectively with different cultures and different socioeconomic backgrounds. So being able to understand that my worldview isn't the same worldview as others. And sometimes it's not what we say, sometimes it's what we don't say that can help us be more culturally competent, because people take offense to things that we may not see as offensive. But being aware that it may be offensive to others is part of being culturally competent, or understanding that in some cultures you don't speak of mental health outside of the family. Understand that this may be a barrier, and the more you show that you're understanding, the more you may be able to open up a door. Acknowledge that everyone is unique. Not everyone is the same. Not everybody is, I'll give you a good example. When I was this age, I saw a couple of counselors, and I always felt like they were treating me like they knew me because they read a book about somebody like me. And right away, that built a wall. And everyone is unique. And when we start comparing Johnny to Joey, we are doing that person a very big disservice, and that person will shut down. So acknowledge the uniqueness. Acknowledge that every situation is unique. Assume nothing. And that's part of what I was discussing earlier. Don't assume that this person is smoking weed or drinking just because they're being defiant. acknowledge that there may be something underlying this that is driving these behaviors, that may be something that needs to be addressed, a la mental health disorders. Provide a safe and non-judgmental place. And that non-judgmental is the culturally competent part, and the you know, not taking the police route and interrogating, build a rapport, as if you will, to where that person feels that they can trust you because you are a safe person to rely on. Be mindful of facial expressions and body languages. What do they say? 70% of communication is nonverbal. You may tweak your eye or smirk at something when a kid is talking. Right away, a wall is going to be built because they're going to read your body language and your facial expression as to where you're not listening to them. You're not seeing them as a unique individual with a unique situation. Define the disorder, not the person. Can they relate? So when you have maybe assumptions that you may feel maybe the situation going on, define the actual disorder, right? Like, well, this is what folks feel when they're struggling with anxiety. When people who struggle with depression, this is how they feel. This is some of the symptoms. Can you relate to some of these? And validate the struggle. It is difficult. Let that person know that you understand that it's difficult. You may not have walked in their shoes, but you understand the difficulties of having these struggles, and promote that they are not alone. I put this on here because I think it's very important. It's very important because in my situation, as well as a lot of folks that I've talked to, a lot of other adolescents, they don't come out to communicate because they feel that they will be judged by being different, right? Kids want to fit in. Kids want to understand that what's going on with them is not something that is they're broken and nobody else is. So promote the fact that a lot of people struggle with anxiety. A lot of folks struggle with depression. A lot of folks run to substances to deal with the symptoms of these disorders. They're not alone when they make these choices to do these things, uh, to deal with their struggles. That they're not the first, and there are other people that understand this. Because when you feel alone, you are a whole lot less likely to come out and discuss it, right? And you're even less likely to come out and ask for help. Because when you feel alone, you don't feel that anybody else will get it, so therefore you don't feel there is no help. So the whole not alone thing is so important. And to wrap this up, recognize the signs and symptoms of both, right? Recognize what anxiety, depression, trauma, recognize what the symptoms of these things are. Also recognize the symptoms of what people are using, and put the two and two together. Assume nothing, but recognize that these aspects go together. To me, folks that struggle with substance abuse, on top of the mental health thing, it's like this. It's the actual very reason why I got into this profession to begin with, because once I realized how strong that combination is together, I realized that there's a lot of folks out there struggling with this that don't get this addressed. They address the substance use, they address the mental health, but never the fact that one relies on the other. In a lot of cases, not all, but that's why I put the gears up on this PowerPoint, because one can be the driving force of the other, and it's very common. Understand the complexity of the situation. Now, I'm not saying understand every nook and cranny of one specific individual's problem. What I'm saying is understand that the situation itself is complex. And that goes to not assuming things, because there are so many possibilities that can be going on. But see it for what it is, not for what you want to see. Make the connections, but don't make the assumptions. Because if we make the assumptions and we're incorrect, we could actually maybe cause more damage. Recognize the possibility of the barriers that I was discussing. So if a kiddo's not being open and honest about things, understand why. Um, and if you don't understand why, recognize the fact that I'm not going to make any assumptions on top of this to create my own why, just to make myself feel like I'm correct. Um, Knowing that you don't know can be a very powerful thing, because when we say that we know everything about this situation, that's when trouble usually starts. And it starts with that kid building the wall. Maintaining awareness of bias on both sides. Am I being biased towards this kiddo because I see marijuana use as a specific thing? Am I being biased towards him because I think his substance use is just an act of defiance and a conduct thing? And then also be aware that they are biased of you. They, you know, a lot of kids don't trust adults. If you're over 18, no, you're not part of us. So be aware that there is bias on both sides, your own and theirs. Be non-threatening and non-judgmental, like I mentioned earlier. That's the one of the best ways to start a conversation, is by being non-threatening and non-judgmental. Promote a desire for growth through positive coping skills. Now, when I say this, if you're talking to an adolescent that you recognize and you've discussed with that person that they are utilizing substances to combat mental health issues, um, discuss the fact that there are positive coping skills that can do the same job as the substance use. It may take a little more work. Substance use is immediate, and it works, and it works fast. So let them know that they may have to work at it, but there are coping skills that they can utilize that doesn't have to be self-destructive, like substance use is. I have met many people in my life, thousands. Number one being their peer, and then afterwards as a professional. Um, and I have never heard, and I tell clients this all the time, I've never heard one person in the midst of their addiction tell me that my life keeps getting better every day. It just does not happen. Once you start down a road, it gets harder and harder to get off of it, and it never improves. It only gets worse. Again, promote that they are not alone. When somebody feels alone in their troubles, they are a whole lot less likely to reach out for help because they feel help is beyond. I can't tell you how many people I've heard say, I've taken it too far with substance use, or nobody gets it, so why should I talk about it? Promote the fact that they are not alone, and you'll go a lot further. That's my presentation. I hope I want to thank um, Dana and Ryan from Family Recovery Centers for letting me do this, because as I said, this is something I'm very passionate about. And I just wanted to help people gain a little bit more awareness of these issues, that so unfortunately, so many kids deal with mental health issues by drowning in the substance use, because it is a quick and easy way to relieve these symptoms. So be aware that substance use isn't just a retaliation thing, or a conduct thing, or a I want to fit in thing. It can very well be that they're trying to self-medicate for a disorder. So yeah, but I want to thank you guys for listening. I want to thank Dana and Ryan for having me. I want to thank Shannon for the amazing introduction. Thank you very much. And yeah, that's it.
Well, wonderful. Thank you so much, Mike. That was a great overview. So thank you. I'm just trying to look at the chat. Thank you for hosting the Spending Time. Will we also receive the PowerPoint? Yes, everyone who is participating today will have access to the PowerPoint. And if you have any other questions, please feel free just to write in the Q&A or the chat, and we'll just take the last minute and wait for any questions that pop up. Just have some feedback, Mike. Thank you so much. Really great. Thank you for this information. It was very helpful. All right. Well, and with that, guys, you have access to our emails as well. So if you do have any questions, please feel free to reach out. We can connect you with Mike. We can connect you with Owens Counseling Center as well. So we have all of those resources for you. And again, Mike, thanks so much. We really appreciate you collaborating with us on this.
Thank you, Dana. It was my pleasure. And as I said, I'm so glad to be able to have the opportunity to do that.
Absolutely. All right, everyone. Have a great rest of your day.
Bye-bye.
Bye-bye.